Okay, so today we're going to discuss about another body fluid. So we have here the serous fluids. So serous fluids are body fluids that could be found here within the cavities of the enclosed organs or body. So basically, it's the body fluid that try to flow between the two membranes within our enclosed organs or body, or our hollow cavities, or the hollow organs or body, or your cavities. So this is found here between your parietal membrane. It's a membrane which try to line the cavity wall. Another one is the membrane that try to cover the organ or your enclosed organs. So that's, we call that one your visceral membrane. Okay, so we'll be talking about today about the three serous fluids. This includes your parietal, your pleural, your pericardial, and we have also here the peritoneal fluid. Okay, so this is the body fluid that try to flow within our cavities of our enclosed organs or body. Its main functions provide lubrication for those enclosed organs that would try to reduce the friction as they try to move. Okay, we have here the formation of your serous fluids. So we consider here the serous fluid as ultrafiltrate of our plasma. So when speak about ultrafiltrate of the plasma, so it would resemble here our plasma, almost the same composition with the chemical constituents present in our plasma, only that they just differ with their concentration. Okay, the production of your serous fluids here is under the influence of the different factors. One is through your hydrostatic pressure, that is the pressure exerted by your heart. And we have also here the oncotic pressure that's being regulated by the concentration of the proteins. In normal condition, between your parietal and the visceral membrane, within the site of your blood vessels and your uh, serous cavities here. So in terms of the hydrostatic pressure, it will have it the same. So therefore, the hydrostatic pressure will not that really be responsible for the normal production of your serous fluids here from your plasma. The most determinant here kung bakit siya nag-move from your plasma, with your plasma going to your serous cavity, would be your concentration of your oncotic pressure regulated by the proteins. Okay, so once within our serous cavities, it should maintain the normal volume of your serous fluids. So it's not just you produce here, the plasma go to that one and try to accumulate. It's also a way or mechanism here that would allow you to get rid or to excrete, to secrete those serous fluids produced within from your plasma, in order for that to prevent to be accumulated within our serous cavities. So that's why secretion here is basically through your lymphatic vessels. But problem with any of this one, whether it's here the accumulation of your serous fluid within your serous cavities, and you call that one as your effusion. Okay, then we have here the different etiology of your effusion process. So the first one, why you have your increase in your serous fluids would be, number one, we have your increase in the hydrostatic pressure related to your congestive heart failure. We have also here the salt and fluid retention. Another one, we have your decrease on oncotic pressure that's related to your nephrotic syndrome, your liver cirrhosis, malabsorption, and we have also here the protein losing enteropathy. Third one, we have here increased capillary membrane leakage related to your microbial infection or simply your infection, malignancy. And lastly, why the fluid here try to accumulate? Because of the obstruction in your lymphatic vessels related to your thoracic duct leakage. You could also have your tumors and many others. Okay, now for the specimen collection. The specimen collection is by your needle aspiration technique. So for your pleural fluid, it's being collected by the process called here the thoracynthesis. For the pericardial fluid, we have here the pericardiosynthesis. And for the peritoneal or ascitic fluid, you have your parasynthesis. For the collection tubes, okay, for the tests, for your WBC count, for your cell count, for your leaf count, then your ETA tube is being used for that. Then for the specimen, for your microbio and cytologic examination, then should be put on your heparinized tube. And then we have here for your chemistry test, so that is a clotted specimen, so you could put it on your plain tube or you could also have your hepatinize through. Okay, then we have here, we need also to classify our effusion as either transudate or the exudate. So when speak about the transudate, so those are the conditions which are related to your systemic disorders that try to affect the normal production and the reabsorption process of your serous fluids. So example of the transudative type of diffusion related to your problem related to your hydrostatic pressure, and we have also here to your decrease in caudate pressure, which has been already discussed. And we have also here the exudative type of effusion related here to your membrane damage related to your microbial infection, or even because of your thoracic duct leakage in the case of your lymphatic obstruction. Okay, then we have here the criteria or the parameters for us then to classify our fluid here to be transudate or exudate. It's very important that we need to classify our fluid as transudate or exudate. It's because here, if the fluid is transudate, so it does not most likely require the normal processing of the specimen. But if the specimen is exudate, then you need to proceed with the testing process. So the first one we have here for the appearance, so transudate is clear, whereas your exudate is more of the cloudy turbid specimen. Another one we have here the fluid serum ratio of your proteins. So cutoff is 0.5 for that. Pag less than 0.5, then transudate. Then we have also here your fluid serum ratio of your lactate dehydrogenase cutoff for that is 0.6. Pag less than 0.6, then we consider it one transudate. Another one we have here spontaneous clotting. So clotting here could be manifested here in your exudate but not the transudate. Another one, WBC count. So the cutoff is 1,000. Less than 1,000 is transudate. Then fluid serum ratio of your cholesterol, the cutoff is 0.3, less than 0.3 is your transudate. Cholesterol concentration, 45 to 60 mg per dl. More than that, more than 60 mg per dl, we consider already that one as your exudate. Then fluid serum bilirubin ratio, the cutoff is 0.6. Okay, so okay, less than 0.6 as we consider it one transudate. Then another one, we have your serum albumin ascitic gradient. So the difference between your serum and your fluid here, the difference of your albumin concentration is more than 1.1, then we consider that one as transudate. But if the difference less than 1.1, then that's your exudate. Okay, we have here general laboratory procedures that we are doing if we are having that serous fluid analysis. The first one, you need to check for the appearance of your specimen. So it's very important because this is the way of you're able to classify if the fluid here is transudate or exudate. As what I've mentioned, so transudate most likely do not require here for further analysis. For the cell count, okay, so the cutoff here for WBC count is less than 1,000. For the RBC count, less than 100,000. But if the values here is more than that, then we consider that one as your exudate. Then for the chemistry examination, most likely when we are doing the chemistry examination test, we tend to compare the values of your different analytes in your fluid with the serum or the blood specimen of that patient. So therefore, you need to have both here the fluid, the serous fluid specimen and the blood specimen of the patient, and try to compare that one, and of course try to take it and compare that one and try to take it as a ratio of that. That's more diagnostic in order for you to classify that one as less than or more than, because by taking here the ratio of the fluid with your serum ratio of the different chemistry analytes. Okay, we discussed first the first serous fluid here. We have the pleural fluid. So the pleural fluid is a fluid that try to flow here within our heart, our lungs. Our lungs cavity. So basically, it could be found here within the cavity that try to cover here your chest wall and even the membrane that try to cover here your lungs. This is your visceral. This is your parietal membrane found in your lungs. Okay, so we have here for the appearance of your pleural fluid. So the normal is yellow, clear yellow. You could also encounter here specimen which is turbid specimen. Turbid specimen signifies high concentration of your WBC. It may be related to your microbial infection, tubercular infection, or even related to your immune disorders. We have here the rheumatoid arthritis. The presence of blood in your specimen may signify either your hemothorax, which is related to your traumatic puncture, or may be related also to your hemorrhagic effusion. So the best way to differentiate the two is first you need to examine for the uneven color of the redness. So if the specimen is uneven in terms of the redness, so that would signify here that one is your hemothorax. Another one, you could also determine that one if that one is your hemothorax or your hemorrhagic effusion by comparing the hematocrit of your pleural fluid with the blood hematocrit. If your pleural fluid hematocrit is 50% higher compared to the blood hematocrit, it would signify hemothorax. That one is higher is because here of the impouring of the blood in the when you are doing the collection process, signifying that one is traumatic puncture. Another one, we have also here specimen which appears to be milky. Milky color here could either be related to your chylus or your pseudochylus conditions. We have here the differentiation between your chylus and the pseudochylus. So chylus, milky specimens related here to your thoracic duct leakage, and the pseudochylus is associated here with your chronic inflammation. For the appearance, so your chylus would have milky yellow versus milky with a greenish tinge in your pseudochylus. For the WBC, so in your chylus, that one is just made up most likely of the lymphocytes, but in the pseudochylus, you have here encountered a mix, different type of the cells. Okay, then we have also here cholesterol crystals absent in your chylus, but it may be present in your pseudochylus. For the triglyceride concentration in the chylus, that one is more than 110 mg per dl, and in the pseudochylus is less than 50 mg per dl. Okay, for Sudan 3 staining, Sudan 3 is actually a stain that try to stain your neutral fats like your triglycerides. Since this one ay mataas ang triglyceride, expect to have here to be stained by Sudan 3. Since dito ay mababa ang triglycerides, so it could have here weakly or positive reaction or even a negative reaction for that. Okay, we go back here with some other appearance. You could also encounter specimen which is brown in color and that related to your amoebic liver abscess. We have also here the black specimen related to your aspergillus infection. Or you could also have encountered highly mucoid specimen or highly viscous. That's your highly viscous specimen because of increased hyaluronic acid related to your mesothelioma, which is a malignant condition. Okay, then we have here the differential count. So most likely, in your pleural fluid, you could find here different cells including your neutrophil, lymphocytes, eosinophils, mesothelial cells, and many others, or even the malignant cells. So the neutrophil, the presence of high concentration neutrophil would signify is related to your infection, related to your pneumonia, your pancreatitis, or even pulmonary infarction. Lymphocyte may appear to be small, large, or even reactive, and that might be related here to your viral infection, malignancy, or even your autoimmune disorders like your SLE and your RA, rheumatoid arthritis. Eosinophil, more than 10% signifies the presence of the air in your lungs. You call this one your pneumothorax. Or the presence of the blood, you call this one your hemothorax. Or it might be also related to your allergic reaction or even parasitic infection. Then we have here the mesothelial cells. Mesothelial cells here is normally present. It's a normal cell lining your serous cavity membrane. So it might appear to be pleomorphic. It means to say it does show here different morphology. It might resemble here your lymphocyte, your plasma cells, or even your malignant cells. Normal mesothelial cells usually appears to be single and would have your large or small in size with the presence of normal or oval nucleus with dark blue or dark purple cytoplasm. The reactive mesothelial cells, on the other hand, usually appears in clusters that one would have eccentric nucleus with a very prominent nucleoli and a very abundant cytoplasm. So normally, you could find right here the mesothelial cells. What makes it abnormal would be the absence of your mesothelial cells. In the absence of the mesothelial cell, you need to consider that one related to your tuberculosis. Okay, then we have here the malignant cells. The malignant cells appears to be would have here the following characteristics. This one would have here abnormal nuclear and cytoplasmic irregularities, abnormal nuclear and cytoplasmic ratio, and we have also here the very prominent nucleoli, and we have also here the cytoplasmic molding, or you call this one as your border community borders. So example of the malignant cells here found in your pleural fluid includes the following. So we have your adenocarcinoma, we have small and old cell carcinoma, and also we have here the metastatic carcinoma arising from your breast or even your lung cancer.